Thank you for coming out on through the Braving Storm Amy, which I thought could be a sort of subtitle to my talk about the menopause, or Storm Nicola, or Storm Sarah, or anything. I am one of the partners and the women's health lead at the Hicks Group Practice, which is Charles Hicks and Roman Gate surgeries in Huntingdon and Bob Manchester, and I'm going to talk about the menopause. So today I want to cover what is the menopause, why, when, who, what to do about it, and then we'll have some time for some questions afterwards. So at the moment there's a lot of talk about the menopause. It seems to me that everywhere I go people are talking about the menopause. Every time I open social media, look on the telly, go into a bookstore, there's a lot of talk. And I think quite a lot of it is down to this lady, who I like to call St. Davina of the menopause. So Davina McCall, I'm sure you all know, is a lady of a certain age, a menopausal lady, who has done a huge amount to bring the menopause into the wider public knowledge. So she did her first programme she made in 2021, Channel 4 programme called Sex, Myths and the Menopause. And that came with the byline, Davina was 44 and she felt like she was losing it. Hot flushes, depression, mental fog. Now she tells her menopause story, busting midlife taboos from sex to hormone treatments. So that was a huge eye-opener for a lot of people, and suddenly people started coming in far more to discuss the menopause. She then made a follow-up programme in 2022 called Davina McCall Sex, Mind and Menopause, which looked at a lot of testosterone, which is quite a controversial area within menopause treatment. And then in 2023, she was on a roll and she did Davina McCall's Pill Revolution. And that is what is her here, lying down. That is Davina McCall having a coil fitted and filmed on television. Apparently she asked the permission of her children for this first, but so she put her through having a coil on television to show women how simple it was. She's now got a book out called Menopausing, which was the winner of the British Book Awards of 2023, and the byline on that was, "We have suffered in silence for too long. It's time to share, to learn, and to take control of our bodies and our lives." So she is really championing talking about the menopause. So what is the menopause? Well, the definition of the menopause is the cessation of menstrual periods, and it became a word apparently in France in the 1820s, but the origins are Greek. Men, month, causes sensation. And kind of by definition, that means you can only diagnose the menopause in retrospect. So you can only be diagnosed as having gone through the menopause when you haven't had a period for 12 months. But there are lots of other words that we use to describe the menopause. So premenopausal, so that's essentially anyone who hasn't gone through the menopause. Perimenopausal, which means around the menopause, and that is probably the highest number of women that I see and what people are often talking about when they talk about the menopause. Menopausal and then postmenopausal. So we will all go through the menopause and we will spend the rest of our lives in a postmenopausal state, and that's probably, depending on how long we're going to live for, about a third or possibly even up to 50% of our lives will be postmenopausal. The symptoms of the menopause usually last for 4 to 8 years, but there's quite a big variation in that. So what is the menopause and what causes the menopause? So women are born with all the eggs they are ever going to have, which I find absolutely mind-blowing. So your tiny newborn baby has got all the eggs that they're ever going to have, which is very different when you compare it to men who continue to produce semen forever, well not quite forever, but certainly Robert De Niro would appear to keep going forever. And the natural process is that those ovaries just run out of eggs, but there are some other conditions that can cause an induced menopause. So the most common and the most easily understandable, I guess, is surgical removal of the ovaries, which is called an oophorectomy, which can sometimes happen if someone's having hysterectomy, or they're having their eggs removed for another reason. chemotherapy, radiotherapy can sometimes cause the ovaries to fail, and some drugs can promote that. A lot of women will have a hysterectomy, but with what we call ovarian conservation, so they will keep their eggs, keep their ovaries, but sometimes the shock of the hysterectomy just turns the ovaries off, so it can induce the menopause. And what is it? So it is related to changes in sex hormones, and the three big sex hormones we've got as women are estrogen, progesterone and testosterone, and these hormones have an impact on multiple body systems, almost everything, and it's the changes in these hormones that cause menopausal symptoms. So this is just a graph of showing the different hormones and as we go through. So the most important hormones that we're looking at through the menopause are estrogen and progesterone. Typically the progesterone level, the dotted blue line there, falls first. For a lot of women, progesterone is a sleep-inducing and calming hormone, so those symptoms related to the loss of progesterone often precede any menstrual irregularities. And then after that, the estrogen levels drop. But as you can see on there, they don't drop in a linear fashion. They fluctuate significantly, and we think that is what causes the majority of the menopausal symptoms, because it's not just related to a low estrogen. Otherwise, women would remain having menopausal symptoms forever. But for most women, those symptoms will stop at some point. Why do we go through the menopause? Well, that's the million-dollar question. Primarily, we live longer now. We live much longer than our cave-dwelling ancestors. The average lifespan of my lovely cave woman there would probably have been 30. So she lived her whole life premenopausally and reproductively active. But now, obviously, we live much, much longer. There are various thoughts about the benefits of the menopause. Why don't we just keep producing eggs and being fertile forever? One, and the two other animals that we know about who go through the menopause, one is killer whales, and apparently the matriarchs of their pods are able to lead them to feeding grounds that no one else knows, so there's a sort of knowledge and understanding that is passed through. And in other mammals, primates, the older women, the older females that have gone through the menopause are no longer fertile, help to care for the young. So that's our role after menopause, I think, to lead people to food and look after our grandchildren. So there we go. When? So when do we go through the menopause? Well, it's usually sometime between the ages of 45 and 55. The average age that periods stop for a woman in the UK is about 51. But some women go through menopause early. So if it is anything before 45, then that's an early menopause. And a premature menopause is before the age of 40. And so premature menopause brings with it specific medical issues, but we're not really going to touch on that now because it's quite rare. 1 in 100 under 40, 1 in 1,000 under 30, and very unusually 1 in 10,000 under the age of 20. So who goes through the menopause? Well, not all women are created equal. Apparently 20% of women have no symptoms, 60% have mild to moderate symptoms, and 20% have severe symptoms. So as a GP, I'm blissfully unaware of the women who sail through it because they don't come and consult with me. They are absolutely fine. And I see far more of the women with the moderate to severe symptoms who are needing help with managing those symptoms. As we get older, about 70% of women will have what we call the genitourinary symptoms of the menopause, and those come on much later, and they're related to the drop in estrogen in the longer term. I'll come back to that in a bit. So, what are the symptoms of the menopause? Well, there's loads. It seems to me every week there's another symptom that's related to the menopause, but I think there's 36 recognised symptoms at last count, and it involves all body symptoms. So often I say, if a woman says to me, could it be related to the menopause? It's quite difficult to say no. And there's quite a common issue with women with mental health problems being not considering that the effect that the menopause can have on those. And I know that certainly there's been some high profile women who have been treated for depression and ineffectively, and then when they actually get proper treatment for their menopause, they feel much better. So the symptoms we can divide into different areas. Systemic symptoms, so a lot of these are due to what we call vascular instability. So this is the fluctuating estrogen levels cause dilation of the blood vessels and increase the blood flow to the skin, and that can cause some of the most problematic problems like hot flushes. That's one of the most common problems people have. It can also cause migraines, palpitations and things like that. The psychological symptoms, anxiety, low mood, irritability, brain fog, concentration problems, they are quite common. They're one of the common reasons that people consult with us, because they're struggling with those type of symptoms. Sleep issues, as I alluded to, can be related to the changes in progesterone, but also if you're having hot flushes through the night, that's very disruptive to your sleep. It can also cause all sorts of problems with your skin, joint pains, breast changes, and problems with libido, so people's sex drive often decreases. There are the localised symptoms of the genitourinary system, so women often complain of vaginal dryness, itching, sometimes they have some increased vaginal discharge, urinary symptoms, urinary infections and painful sex. So essentially it can affect absolutely everything. So what can we do about it? Well, first of all, I thought we'd look at what the lifestyle measures and what the NHS recommends for this. So this is my personal favourite: get plenty of rest and get regular sleep. So you're telling someone whose symptoms are causing them to not sleep. Actually, what you really need is a good night's sleep. Oh, thank you very much, that's very helpful. It recommends relaxing things like yoga, tai chi and meditation. It also stresses the importance of exercise, because we know that exercise is very useful for most things, but it's also specifically useful for women going through the menopause, and the types of exercise they're talking about are weight-bearing exercise, which helps with your bones, so that's walking, running, dancing, things like that. And also exercise that gets your heart rate up, so moderate aerobic exercise, so whether that's swimming, cycling, or anything else. And the NHS guidelines say you should be aiming for 150 minutes of that a week, so that's 2.5 hours. It recommends that you talk to others, so sharing your problems, and certainly there is some evidence that even if women come to see their doctor and they have a sympathetic consultation with their doctor, even if they don't have any treatment, they're better able to manage their symptoms. Don't smoke, don't drink excessive alcohol, maintain a healthy weight, and then there are other things to manage, things like the hot sweat, so dressing in layers, making sure your bedding is not too heavy, fans, etc. And then diet, what do we need to think about for diet? So there's a lot of information out there, but most of it is similar to the general education or the general information that we say to people about their diet. There's only one thing that's sort of slightly specific. So the importance for diet as you're going through the menopause, calcium rich, because after the menopause is a time when your bones become less dense. So you want to be really looking after your bones and making sure you've got plenty of calcium in your diet. There's lots of calculators online that you can put in how many cups of tea, how many servings of macaroni cheese, etc. you have. And that's particularly important in people who are avoid cow's milk, to make sure that if there are any dairy replacements they're taking are actually fortified with calcium. Vitamin D is important. This week is Vitamin D week in my family. Everyone in the UK is advised by the NHS to be taking vitamin D throughout the winter months, so that's kind of October to April, because we get a lot of our vitamin D from the sunlight and there's not enough sunlight in the UK to maintain us. So everybody should be taking vitamin D throughout those months, and certain people need to be taking higher than normal doses. 5 portions of your fruit and vegetables a day, which again is standard NHS advice, and there is some talk in other areas about whether that is enough. Should we be saying 7? Should we be saying even more than that? Should we be saying 9? But I think the NHS takes a pragmatic view that aiming for 5 is better than nothing, and probably more achievable for a lot of people. Avoiding ultra-processed food is another hot topic at the moment. And watching portion size, because there is a lot of women find that as they go through the menopause, it becomes harder to maintain their weight. It's easy for them to put on weight, so keeping an eye on that. There's advice about avoiding triggers. So for some people, spicy foods, caffeine, alcohol can make their hot flushes worse. So avoid those if people find that they are triggers. There has been talk in the past and continues to be about the role of phytoestrogens. So that's estrogens from plant foods, primarily soy. So soy tofu. This came from some studies that showed that Japanese women had lower levels of menopausal symptoms, and they had high soy in their diet. So the jury is out. Some people find it is helpful because these are can mimic estrogen, but the evidence isn't really there. But it certainly goes along with a sort of avoiding ultra-processed food, increasing your vegetable intake, etc. So, and it's unlikely to be harmful for most women. So, what are the guidelines about the medical treatment of the menopause? Well, NICE, which is the National Institute for Health and Care Excellence, have got guidelines that were updated last year. It's a 105-page document, so there's quite a lot to read there. But there are specific details, and I'm just going to cover the main bits of it. So what do they say about the diagnosis of the menopause? Well, a lot of women come in and say, I think I'm menopausal, can I have some blood tests? And the guidance is that usually blood tests are not advised. Menopause is a clinical diagnosis, so if you are over the age of 45, your periods are irregular, having menopausal symptoms, then it's probably the menopause. Blood tests are only recommended in people under the age of 45 or in other specific circumstances. We can't do those blood tests if people are on, for example, the contraceptive pill or other hormonal methods, because we're measuring hormones and they're not their own natural hormones. So once we've diagnosed somebody with the menopause, what is the treatment? Well, NICE recommend that the mainstay of treatment for menopausal symptoms is HRT, Hormone Replacement Therapy. So that does what it says on the tin. You're replacing the hormones that are fluctuating and you're losing. So that can be systemic, so that is hormones that you take and they go throughout your whole body, or local, which is hormones that you take and they're just used locally in the vagina. And they have different roles and they're used in different times. If in women who don't want to or are unable to take HRT, then NICE recommends CBT, which is cognitive behavioural therapy, specific to the menopause, to help women manage primarily deal with the hot flushes, because it won't make any difference to them coming, but to manage how they do, and also these psychological symptoms, which are often quite problematic. In the previous guidelines, antidepressants were in there. They're no longer in there unless someone is specifically depressed. So we used to use them for people, or we used to offer them for people who were having hot flushes and mental health symptoms, but now it's only if they actually reach the threshold of depression. So, HRT, what is it and how do we use it? So the main hormone that we look at replacing is the estrogen, and that's the mainstay of treatment, and that comes in variable doses. Stabilising someone's estrogen levels stops that wobbling that we saw in the previous graph, and can help with most of the symptoms. It can be taken either orally, which is how we've initially started prescribing it, and more recently there have been changes in the guidelines and changes in the availability of so we often use it through the skin, so that's either as a spray, a patch or a gel that you rub in. There is some evidence that some of the side effects of HRT are less and the risks are less when we apply it through the skin rather than tablets, so it tends to be my first line choice is to use it that way. Especially it doesn't increase your risk of blood clots, which the tablets can do. The dose is variable and it depends on people's symptoms. It's not, the guidelines say that we shouldn't use blood tests to test it, we should be treating the symptoms rather than the blood levels. And there are lots and lots of varieties of HRT, so I often say to someone, let's try this and see how we go. If it's not working, there are other things we can do. Progesterone is the second hormone that we look at. Now, if you don't have a womb, so if you have had a hysterectomy, you don't need progesterone. It is not used in the standard HRT. However, if you have a womb and you take estrogen, then it thickens the lining of the womb, increases your risk of bleeding and increases your risk of developing cancer of the womb. So any woman who is going on to HRT who does have a womb needs to have some progesterone to protect the lining of the womb. That can be as a tablet, it can be through as a patch, in a combined patch, it can be just directly in the womb in the form of a Mirena coil, which we also use for contraception. And there are also formulations that can be used vaginally or rectally, but it's vitally important that women who have a womb and are on estrogen have progesterone as well. There are different ways you can take that, so if someone is very early on in their menopause, we will give them a higher dose of progesterone for 2 weeks a month and then no progesterone, so they would still continue to have monthly bleeds. As you progress through the menopause, we give you a lower dose all the time, which means that you shouldn't get any bleeding, which people are often very grateful for. Testosterone is the third hormone that's discussed in relation to the menopause. That is a separate one and not part of standard HRT, but there's a lot of discussion about that, and I'll come back to that a bit later. So what are the risks of HRT? When I was at medical school, which was a long time ago, it was thought it was a panacea. It was wonderful. All women should be on it forever. It was the secret to eternal youth. And why would you not want to continue taking these hormones that make you young? Then there was a big study that showed that it actually increased the risk of breast cancer. So then there was a big scare and lots of women stopped taking HRT and HRT uptake went absolutely dropped off a cliff. Now we're back in the middle zone. So breast cancer can slightly increase risk of breast cancer. HRT can slightly increase your risk of breast cancer. I'm going to come back to that because there's some interesting information about it. It can increase your risk of womb cancer. As I was discussing with progesterone, that reduces that risk significantly. Ovarian cancer, there's some evidence that it slightly increases your risk. Your risk of ovarian cancer is very low and it increases slightly if you are on long-term HRT. What does it do for your risk of coronary heart disease? So heart attacks, strokes. The jury's out. It looks at the moment like there's no statistical difference. So some studies showed that it was protective, some studies showed that it was harmful, but actually overall that it doesn't make a significant difference. Dementia, what does it do to your risk of dementia? There was one study that showed women who started HRT age 65 had an increased risk of dementia. However, that's not the population that we're usually dealing with. Most of the women we're dealing with are between 45 and 55, and I would very rarely, if ever, start HRT in a woman who's older. So in younger women, there's no conclusive evidence that it causes any problems. And what are its benefits? Well, apart from resolving your symptoms, it's also licensed as a treatment for osteoporosis. So osteoporosis is thinning of the bones, which can lead to women having, or people who've got it having fractures, particularly hip, spinal fractures and wrist fractures. So HRT can be used as well as treating the symptoms as a treatment to prevent osteoporosis. And there is possibly a small benefit in your risk of stroke if you take HRT. So a lot of these are very individual, and people take different, have different ideas of risk and benefit, and so it's a very individualised discussion with each person who's wanting to go onto it. Breast cancer is the big one, and that people are often very worried about. So breast cancer is the most common cancer in the women in the UK. 150 women every day are diagnosed with it, and 1 in 7 women in their lifetime. There's a lot of very useful information over on that first stand in the corner about breast cancer. So what about HRT in relation to breast cancer? Well, I find this picture very, very helpful. So this is women aged between 50 and 59 per thousand. So 23 cases of breast cancer in that population. If you put women on combined HRT, so estrogen and progesterone, you get additional 4 cases per thousand. If women are on estrogen-only HRT, which they can only be on if they don't have a wound, you have 4 fewer cases. But then I just like to compare that. The contraceptive pill is not relevant. We don't put people on that over 50. But I like to compare those risks with 5 additional cases in women who drink more than 2 units of alcohol a day. So women are often very worried about HRT, but will happily have a big glass of wine a night. Actually, the risk is higher with alcohol. 3 additional cases if you're a smoker. So again, a similar increase in risk. 24 additional cases, so over double if women are obese, so with a BMI of over 30. And that's primarily because estrogen is a hormone that likes fat. And so being obese is a very big risk factor for breast cancer. And then 7 fewer cases in women who take at least 2.5 hours of moderate exercise a week. So there are things, that's why the guidelines are what they are. But when I show people this graph, they're like, oh, actually I thought it was going to be much higher. It's an individual discussion with people, because some people will not want to do anything to increase their risk. Some people will be struggling significantly with their symptoms and say, you know what, I can't keep going the way I'm going. I will take that risk. The risk is related to the duration of use of HRT, and the risk declines after you've stopped the HRT, but it takes 10 years to get back to where your baseline risk would have been. So there is an increased risk of breast cancer, but it needs to be put into perspective. So the other recent media storm about the menopause was about this lady, Louise Newsom. So she is a menopause expert. She has a network of menopause clinics over the country. And she was recently investigated by Panorama, September 24. She was investigated because she's known for prescribing very higher than regulated doses of estrogen. And so there's a huge discussion about this at the time. She lost her accreditation with the British Menopause Society, of which she was a very well-known member, and caused alerts to be issued from the British Menopause Society, the Royal College of General Practitioners and the Royal College of Obstetricians and Gynecologists about the dangers of using high-dose estrogen. They have the risks of prescribing higher than the licensed doses are an increase in risk of all the problems that we've been talking about. So it caused a massive awareness, and we still have patients who were prescribed high doses at private clinics who are asking us to prescribe, and we are saying, no, we're not prescribing because of the risk. the private clinics have seen over 45,000 patients since 2020. And so this is a huge number of women that may be on higher than licensed doses. But on the other side, there are also complaints about the BBC saying, there's Mariella Frostock saying, documentary about the menopause doctor could stop women taking HRT and increase the levels of fear again. So it is an ever-evolving field, and I'm amazed that we still don't have a lot of the answers, and studies are continuing on. So what else can we do about the menopause, or what else do some people think we can do about the menopause? So if you Google treatments for the menopause, this is what I love. My personal favourite is these two almost lightsaber-looking devices, which are portable vaginal rejuvenation wands. Now, she looks lovely. I don't know whether she needs her vagina rejuvenating. There's, and I just have a little bit of fear that if I were to buy a portable vaginal rejuvenation wand, I would come downstairs to find my children playing Star Wars with it. There's no evidence it's helpful. This other thing in the bottom are magnets. So perimenopause, and PMS, hormone-free alternative. They're magnets that you put in your pants. Again, I'm not entirely sure about the evidence. They're probably unlikely to be harmful. There are lots of menopause supplements, and certainly if you walk into Holland and Barrett, you can be absolutely overwhelmed by those. And then there are the other things like cooling gel body pads that you can use on your bed. So NICE is very specific about these complementary therapies, and it says it's unable to recommend. So the common ones people talk about are black cohosh, isoflavones, and St John's wort. And the reason they're unable to recommend those is that there probably haven't been adequate studies on it. There are multiple preparations available, and there are also possible interactions with other medications. So certainly a lot of women will try those, and if they help, fine, but they're not, the guidance is not there so that we can recommend that they will be helpful. The other hormone that I said we would come back to is testosterone. So testosterone we know primarily is the male sex hormone. However, women do have testosterone, and women's testosterone levels probably fall as they go through the menopause. The use of it remains fairly controversial. Davina went on it and loved it. She said it was wonderful, it gave her mojo back, it certainly gave her libido back, and it gave her lots and lots of energy. So what does NICE say about testosterone? So NICE recommend that you can consider testosterone supplementation for people with low sexual desire associated with menopause if the HRT alone is not effective. So that means that if one of your complaints about is low libido, the first line is to try and make sure you're on adequate estrogen, because that may well make a difference. And that it but one of the big problems with testosterone is that there's no licensed preparation in the UK. So testosterone can't be taken by mouth, it gets destroyed by the gut. So it needs to be used either as an injection or through the skin. The preparations in the UK that are available are ones that are designed for men. So some women end up taking approximately 1/8 of a sachet of testosterone gel to rub onto them a day. Now that's quite complicated to be trying to use that. And in Cambridgeshire, the guidelines are that it needs to be initiated and stabilised by a specialist, so that is either a specialist GP or a gynaecologist at the hospital. There is no evidence that it improves the mood, energy, cognition, musculoskeletal health, or make you feel as wonderful and young again as Davina does. However, people often say that they do feel significantly better. And it should only be used after the biopsychosocial approach has excluded other causes. And I love these. Other causes of low libido are relationship problems. Okay, so maybe if I don't like my husband, I don't want to have sex with him. All right, that's fine. Psychological disorders and medication side effects. The side effects of testosterone can be increased hair growth, acne and weight gain, and very rarely it can cause problems such as hair loss, alopecia, voice deepening and clitoral enlargement. So it is an ongoing area for research and development, and I'm amazed that there is no licensed testosterone in the UK, because I think there would be a massive market for it, and I think I'm sure it will be coming at some point, but at the moment GPs are not able to prescribe testosterone unless it's been initiated and stabilised by a specialist. And when we look at the specific genitourinary symptoms of the menopause, which can come along a lot later. So I often am seeing much older women who are having these problems that I say to them, when was your last period? They're like, oh, I don't know, 20, 30 years ago. But it's the long-term lack of estrogen that can cause some of these symptoms. And the NICE recommend that one of the first lines of treatment is just a lubricant, and then estrogen used just in the area where you need it, so just in the vagina, and that can either come as a tablet, a pessary, a cream, a gel, or there's a ring that sits in the vagina. Now these give you a estrogen in the vagina and near the bladder where you need it, and it doesn't go around the body like the systemic HRT does. So they're safe to use long term. They're available over the counter. You can buy them without a prescription, and they are often an option for women who can't use systemic HRT for whether they've had breast cancer or they've got a strong family history. The level of estrogen that is going around the system is very low, so that is not that's an option for those women. And what I do with people with that is we give them a course for a few months, things get better, wait, things get a bit worse, and then we just give them another course, so they don't necessarily need to use it all the time. So, as I said, menopause is everywhere. Celebrities, you can't stop them talking about it. The latest one I've seen is this Mariella Frostrup and Bells Berry, who is Mary Berry's daughter, who's got a book, Menolicious, which is about recipes that will help you through your menopause, and that's a Sunday Times bestseller already. This group of ladies on the top there were Boots ambassadors for the menopause. Gwyneth Paltrow, of course, has something to do with it, and Michelle Obama has spoken about it. So it is everywhere. However, there are some people who say, actually, why are we worrying about this? This is a normal process that everyone goes through. Are we over-medicalising a normal process? Or is it about time we talked about something that is causing so much distress for so many women? And I think there's probably a bit of both. And certainly I am seeing far more women about the menopause than I did 15, 20 years ago. That might just be because I'm of a certain age myself and they're coming to see me, but it is much more widely discussed and there's much more awareness of it. There are workplace initiatives about the menopause, there's the Man's Guide to the Menopause, and also there was a recent change that meant that instead of having to pay for every HRT prescription, you just pay a one-off fee per year that covers the prescription. So that was a victory for these women who are campaigning for more awareness of the menopause. What else do we need to think about as we go through the menopause? Well, when do you stop the HRT? Some women take it forever, but the advice is that you take it to control the symptoms and for a shorter period. When people are stopping HRT, I usually say don't stop it suddenly, because you will have a significant drop in the estrogen. You may well get symptoms coming back. I like to try dropping it down gradually, but with the awareness that you may well get the symptoms back, and we can always go up a step if need be. But I'm very keen to get people off HRT if they've been on it too long, like 10 years. But some women will say, you know, my life is not worth living without it. I'm going to stay on it forever. I accept the risks. So we do have some patients in their 70s and even their 80s who continue to take it, but those are personal decisions there. Weight loss injections, we are seeing a huge number of people getting weight loss injections privately. The Mounjaro, Wegovy, Ozempic, they can have an interaction with the oral parts of the HRT as they can with contraceptive pills. So that is something that we need to be aware of if people are sourcing those elsewhere. Contraception. HRT is not a contraceptive. The doses in it are much lower than they would be in a contraceptive pill. So women, there is a theoretical risk that they could still get pregnant. We've all heard of people who've gone, oh yeah, so-and-so's auntie, she thought she was going through the menopause and she then had a baby 9 months later. So we can use all contraceptives alongside HRT in certain women. What the guidance is, once you get to 53 or so, then your risk of getting pregnant is absolutely minimal, so contraception can be stopped. But for a lot of the women at that point, if you say to women in their 50s, how would you feel if you got pregnant, their face is like what? Oh God, no, thank you very much. Bone health, so that's one of the things that does drop off after the menopause, so your bone density decreases, so it's important to be looking at the things that you can do to prevent that. So calcium-rich diet, well, weight-bearing exercise, not smoking, vitamin D. And then screening, so breast cancer screening, cervical cancer screening, and also bowel cancer screening, and one of my colleagues is going to talk to us a bit about those later. This is the graph of estrogen prescriptions in the NHS, and the start is July 2020 and the end is July 2025. And if you look at the amount of estrogen that we are prescribing now, it has risen by almost 5-fold. So that is partly the Davina effect, and partly women just being more aware and wanting to take charge of their symptoms. This resulted in massive shortages of HRT, which were a huge problem for us 2 or 3 years ago, that now mostly seem to have been resolved. And that was just purely because the number of women taking HRT rose significantly. So it is, and I can't imagine that will stop anytime soon, because for some women it transforms their lives, and some women come back to me after I've prescribed them HRT and almost kiss me. They'll feel so much better. So where do you go if you need information? Obviously go and see your GP. Most GP surgeries will have someone who is more experienced in looking after menopause than others, and your receptionist will be able to put you in that direction. The NHS website has got a lot of information. Women's Health Concern, which is the public patient arm of the British Menopause Society, have got a huge amount of information, and that's where some of my slides have come from today. There are other websites that put information like Positive Pause and Manage My Menopause, but it is one of my biggest things as a doctor is knowing where to look for the right information. So these are websites that I direct my patients to if they are asking, should I take HRT, what else can I do? These are all very sensible and useful advice for those people. Okay, any questions?
What dosage strength of vitamin D should you take? Standard NHS advice is 400 units a day. A dose that can be bought without prescription. Doctors can prescribe higher doses for people who are vitamin D deficient. I've heard that some people, such as people being treated for thyroid conditions, cannot take HRT. Thyroid treatment should not prevent people from taking HRT medication. The best, most effective treatment for the menopausal symptoms is hormones, but a lot of people can't take hormones. What is available for them is very different, and it's a significant challenge to manage people who can't or don't want to take hormones. Some people find that it's useful to take soya and tofu because they contain phytoestrogens, which are plant-derived compounds that mimic the body's own estrogen hormone. Do some women have naturally high testosterone levels? It is unknown, but there's certainly quite a wide range of normal for women's testosterone. It's much lower than the men's range, and there is a lot of variation. What is menopause, and when does it usually happen? It's when your periods stop, marking the end of fertility. It usually happens between ages 45 and 55. What are the most common symptoms? Hot flushes, mood changes, poor sleep, vaginal dryness, and changes in periods are common. How is menopause officially diagnosed? If you haven't had a period for 12 months, you're likely postmenopausal. Blood tests are sometimes used if you're younger. Why is it important to continue health checks after menopause? Hormone changes can affect bone and heart health, so regular checkups and screening are important. What screenings or tests should women have around this time? Continue breast and cervical screening when invited, and discuss bone density or heart checks with your GP. How does menopause affect heart and bone health? Falling estrogen levels can increase risk of heart disease and osteoporosis. What are the options for managing symptoms? HRT and non-HRT. Hormone replacement therapy. HRT can replace lost hormones. Other treatments and lifestyle changes can also help. Is HRT safe, and who can take it? For most women, the benefits outweigh the risks. Your GP will help you choose the best option for you. Are there lifestyle changes that can help? Eating well, exercising, reducing stress, and limiting alcohol and caffeine can all make symptoms easier to manage. How can partners, family, or employers support women going through menopause? Understanding and open conversation help a lot. Workplaces can offer flexible support and awareness. What services or clinics are available for menopause support? Your GP can refer you to menopause or women's health clinics for advice and treatment. When should I see my GP about menopause symptoms? If symptoms affect your daily life, or you're unsure about treatment options, book an appointment. The information provided is for general information only and should not replace personal medical advice. If you have any concerns about your health or screening schedule, please speak to your GP or practice nurse.
Any more questions? No? Lovely, thank you.